So good afternoon, everyone. As I introduced myself yesterday, I'm Shalmali Joshi, an assistant professor at Columbia Department of Biomedical Informatics, and I do work in AI machine learning for clinical healthcare, focusing on issues of robustness, reliability, trustworthiness, all of that. Today, I'll be talking about where we are in terms of the utility and progress in foundation models in clinical healthcare. The adaptive reasoning part is barely a slide. I'm going to talk about it more on Thursday. Today, it's more of the evaluation of state of the art and the gaps that currently exist. So you all know and are very familiar with the data revolution in the past decade or so in data that's been available for research purposes, like the UK Biobank, all of us. But on the other hand, you also are familiar with the fact that digitization of electronic health records has basically accelerated the development of an analysis of this kind of data. For example, as of 2021, over 97% of electronic health record data in the United States across healthcare institutions has been digitized, on top of which this data was also sort of made available for research purposes, and there have been many efforts in that direction to try and understand what insights we can gain from that kind of data. And so today's work is particularly focused on structured electronic health record data, although health record data is pretty broad. So the proliferation of AI and machine learning in clinical healthcare has been happening for a good while now, a little over a decade. But I want to start with two major examples of sort of stories that have made the rounds in recent years. Both of these are machine learning models that were designed to detect sepsis in ICU patients using clinical healthcare data that is recorded within the ICU. One is the EPIC sepsis model, which is a proprietary model developed by the largest EHR vendor in the United States, which is EPIC. And the other model, Sepsis Watch, developed at Duke. And we would hope that these models would have actually potentially improved detection of sepsis, treatment of sepsis. Sepsis, if you're not familiar, is a hospital-acquired infection. It's very subtle to detect. It's very hard. And Julia has a lot of good work in the area, but it's a hard problem in the ICU. And if it's not detected early with antibiotic treatment initiation, the inflammation can spread and can prove fatal. So it could be a very high impact problem if we could actually address it. The problem is we don't necessarily know what the EPIC sepsis models were trained on, and when they were deployed across healthcare institutions, almost 9 of them, the performance was highly variable across all of these institutions. These machine learning models raised so many false alarms, which essentially made it very difficult for clinicians to tell what is an actual signal versus what is noise, to the point where these models were ignored. So generalizability of AI and machine learning models outside of their training distribution, at least in the case of the EPIC sepsis model, which we don't even know what the training distribution is kind of a hard problem. And to see how much the performance varies, you can see the variability of the EPIC sepsis model across 9 healthcare institutions. And the performance basically gets close to random for when the sepsis incidence is very high, which are patients that have a lot of comorbidities, complex patients, like patients with cancer. The orange dot is just a different definition of sepsis. And if your model is effectively close to random, you probably would be very, very worried. So where we are is quite far in terms of making positive impact. And to understand how we could fill the gap, we probably need to understand what it is that machine learning models are failing at. So to start with, let's just be clear on the characteristics of health data. Health data as you've seen before in multiple talks, is basically an irregularly sampled sequence of events. It's multimodal, heterogeneous. The data is sparse. The signals we collect are based on hypotheses of underlying things that might be happening to you. It is, of course, irregularly sampled, and you use healthcare in bursts. When you're sick, you're using it more. When you're fine, nobody touches the healthcare system. And the missingness, whatever data is collected for you, is informative of potential underlying physiology, but is also confounded with other things like how you use the healthcare system, what kind of access you have, and generally clinical practice decision making. So beyond your physiology, it is also mixed up with all of these other factors. So in order to try and understand where the generalizability breaks down, one important notion, at least at the right abstraction of machine learning, that we may want to think about as a unifying view to think about the fragility of AI behavior is distribution shifts. And why is distribution shift an important way to think about it, at least I think so, is because it captures a large number of things that we worry about. One is the intrinsic statistical challenges of observational data, like missingness, confounding, selection bias, so on and so forth. Generalizability is inherently a distribution shift problem. And then the third thing it helps us to think about is the fact that deploying a machine learning model itself will induce a distribution shift in the data that you're actually working with and in the system that you're going to deploy the model in. So what I'm going to talk about today is things that we may need to start thinking about to sort of fill these gaps. And so the first thing is barely just let's benchmark where things are in terms of model performance and where the breakdown of generalizability is actually happening. And then we can potentially address this either using statistical methods or other methods. The second thing is and this is not work that only everybody in machine learning in healthcare is pretty much trying to address, is what are good representations of multimodal data so that we can actually scale these models and capture all the variability that we inherently want to capture. And then finally, when I talk about reasoning, I'm mostly talking about probabilistic reasoning. If we actually think of AI and machine learning models, particularly foundation models, we really want them to have a higher bar than just being able to predict on certain tasks. We really want some sort of reasoning capability. And so what would we want in order to enable those? And so this was covered in multiple talks. I'm going to go through this fast, but you're now familiar with the paradigm change that we went a couple of years ago, going from discriminative models where we would take one particular task, collect data for that task, solve a discriminative machine learning problem like a supervised learning problem, and then evaluate on related but small number of tasks. Now we are in a paradigm where we are going to train massive models, typically as some sort of autoregressive model, on some data that looks like a sequence. It need not be, but this is an example that is going to extrapolate to EHR data. That's why I'm using it. And we would train these models to solve very simple tasks, like in the case of natural language, next token prediction. And then once we train these models, we're going to collect small amounts of data on a large number of diverse tasks to fine-tune these models. And the expectation is that these models perform really well on a range of diverse tasks, much more broad than the earlier paradigm. That's where we are, which has also basically resulted in a lot of interest in looking at foundation models to model structured EHR data. Structured EHR data is all the tabular data that gets recorded whenever you visit a hospital. That is medication codes, lab codes, diagnosis codes, prescription data, everything. So naturally, this is basically an irregularly sampled sequence of these tabular information. And so if you think about a patient timeline, basically looks like this. We have diagnosis codes, medication, procedure, lab codes. Effectively, these are codes within a vocabulary and therefore a language, easy to tokenize, and take the paradigms of large language modeling into structured EHR modeling. But structured EHR is special in that it has numerical values. On top of which, the irregular temporality itself is very important, which is distinct from language. Finally, the length of context that you might want to model for a given patient is important. It's tied to the patient physiological status. Maybe if the patient is older, we have much longer trajectories for a patient, and so on and so forth, which means that the pre-training losses you might want to use have to be distinct. But that doesn't mean that we cannot just take existing autoregressive paradigms and see how much they benefit this kind of data. So we started with this effort of trying to understand how good these models are. What's happening right now in the healthcare system is that we cannot actually share data across healthcare institutions. So when we say foundation models in healthcare, particularly focused on structured EHR data, what is happening is that these models are being trained in-house at a given healthcare institution on the data for that healthcare institution with whatever architecture and whatever pre-training losses people might want to try. And then there's a diverse set of fine-tuned tasks or just downstream tasks that you may want to evaluate utility on, but it is coming from the same site. And then you're going to see how the model performs on those tasks. Testing for transportability has still been a challenging problem. The state of the art that we are going to look at are these 6 models. Some of them are BERT-based, some of them are GPT, Llama, Mamba state space models. The one you might not be familiar with is Motor, which was explicitly designed for structured EHR data. And these properties are the things that vary across, the main things that vary across all of these. When I say MLM, it means masked language modeling. When I say NTP, it's next token prediction. And Motor is unique in that it uses time to event loss, which, as Rajesh mentioned yesterday, is important for modeling sensor data and competing events. This doesn't do competing events, but it models sensor data, which is important in structured EHR data. As you can see, there's a lot of variability in what design choices have been made in terms of how to model the temporality, what data sources to use, how to even capture temporality through age, through timestamps, et cetera, and what is the representation of these codes in the first place. And these choices, design choices like context length, have implications for patients in that if you use a context window of 8,192 in an attention-based model, it means you can cover, at least in Columbia population, over 99%, 0.7% of patient trajectories. But if you use a smaller context window, you can only cover a little over 99% of patient trajectories. So that has implications on how much history you're modeling and how the downstream performance is going to look like. Okay, so people have been trying different choices of how to even capture this data. Some models have tried to look at, let's insert artificial tokens to designate things like visit start, visit end. How to represent time is very different. For example, people can represent time as a decomposition of year, date, month. Some directly use some sort of absolute notion like age or time since first visit, and so on and so forth. It's very hard to do a combinatorial ablation of what is actually good representations versus not. So what we are going to do is we are going to take exactly how these papers were published and then see what is happening on Columbia data. Most of these models, except CherBERT and CherGPT, were developed elsewhere. CherBERT and CherGPT were developed at Columbia. And then, of course, the choice of pre-training tasks. You can do a BERT-type model, which does masked language modeling. You can do next token prediction. Motor, as I said, is slightly unique. It represents EHR data not as a irregularly sampled, not just as a sequence of tokens, but a visit is represented as a vector, which we obtain an embedding for. And then you would actually try to model a time to event for all the possible diagnosis lab codes that you see in the data. So about 8,000 lab codes were used for pre-training. To give some context about Columbia data, it's a very large academic medical center, can provide specialized care. The data that we used has about 5.3 million patients. this is basically the demographic breakdown. What you're seeing on the right is histograms of conditions, procedures, labs, and medications. But you're also seeing that we have a subset, access to a subset of Stanford data. And as you can see, there's a clear distribution shift in terms of the density of the codes across all of this. And so we are going to basically test transportability only for one of the models that was trained on Stanford, and we could actually test on Columbia data. The thing about structured EHR is that harmonizing the data is a significant lift, and we did that. But I brought this up because it has implications on when and how we can test transportability in the first place. But I'm not going to go into the details of what we did here. One of the big problems in even benchmarking is that there's insufficient diversity in downstream tasks. Let's restrict ourselves to tasks that are even prediction tasks. But even then, we haven't really, at least in state of the art, tested beyond a couple of patient outcomes tasks like patient mortality, readmission rates, and so on and so forth. So we decided to create 14 new tasks that range a wide range of prevalences across acute conditions, chronic conditions, and patient outcomes. These are all still prediction tasks, just binary prediction tasks. And we're going to look at whether these foundation models, so-called foundation models, perform well on this level of diversity. And I'm going to go straight to the results. And this is only like pre-training the model, taking the patient embeddings, and linear probing them, which means you're going to put a logistic regression head, just tune the logistic regression head, and look at the performance on all of the 14 downstream tasks. And on top, you're going to see the performance for a range of the x-axis in each of the plots is the range of label prevalences, very tiny prevalence to a reasonable prevalence. And the top row is smallish data regime used for the probing, and the bottom is largish, whatever we have available in the data set used as the data for probing. And as you can see, the performance when the label prevalence is really low, the dashed line essentially is the best hand engineered baseline, which is a tabular data model like XGBoost. And these are the baselines that you might want to expect that these foundation models do better than that baseline. And the transport model is one that is trained on Stanford data but tested on Columbia data. And so as you can see, when the label prevalence is really low, these foundation models are not doing anything for our clinically meaningful tasks. These tasks were particularly designed to be clinically important, but also more difficult in terms of the learning task. The Breyer score is the middle column. The Breyer score essentially looks at, gives you some, not exact, but some notion of uncertainty or calibration of the uncertainty. And as you can see, the Breyer score also essentially goes up, which is bad as the prevalence goes up. The only thing that we are seeing as the utility is if we look at the sensitivity of these models to different healthcare utilization patterns of patients, we can see that the foundation models, so-called pre-trained and probed models, are less sensitive to patient utilization patterns compared to the hand-engineered baseline, which seems to be really sensitive. And so depending on the task and label prevalence, you're not seeing clear winners among these sets of foundation models. And that can be problematic to even say which ones, which architecture choices, which data representation choices, what kind of pre-training task is actually winning out, and what we should actually put our effort in order to build the next best model. But there is something happening in that it is for at least certain kinds of tasks, these foundation models demonstrate some utility over hand engineering and modeling these data. But we are nowhere near the kind of level of transportability and generalizability we would want to see, because partially due to the representations, there's a clear distribution shift in the coding practices in Stanford and Columbia. Obviously, some of that needs to be overcome through harmonization, which we did, but it's impossible to overcome that fully. And everybody is exploring other kinds of representations, such as text serialization, to overcome those problems. But we don't necessarily know how much they bring to the table. But that's basically where we are, at least in terms of the current state of the art structured EHR foundation models. I want to just quickly highlight a simple example of lupus because it's an important autoimmune disorder. And as you can see, for the most part, you can see the foundation models doing something meaningful over tabular data. So if there's a slightly higher prevalence in the task definitions, you can actually get good, reasonable predictive performance. Although I would want to say that if it's really a foundation model, the downstream tasks need to be much broader than just binary classification. But this is what we tested to start off with. What we are currently looking at, obviously, is better representations of the structured text. And hopefully, so this is not new. A lot of people are trying this, text serialization as an input representation. But we are not just interested in performance. We are interested in what properties beyond performance, such as uncertainty, calibration, can we obtain with better text-based representations of EHR data. What this is essentially showing is that if you just blindly serialize those encoded tokens into text form and put it through an open LLM, the AUROCs for a particular prediction task like mortality are fairly comparable. But as I said, we shouldn't stop at just looking at whether performance is comparable. And we should expect more. Okay, that's where we are. So if we wanted to actually then think about multimodal data, things start to get even more interesting. And here I'm going to talk about a slightly different use case where we know that deploying a multimodal model itself is going to induce a distribution shift, because the point of multimodality in machine learning is to say that there is sufficient signal in collecting different modalities that we should collect data at a different rate than what is being collected in the training data. And so the example I'm going to quickly give is that of detecting structural heart disease, which is typically detected using an ultrasound of the heart, which is expensive in the United States, not necessarily elsewhere, from ECGs, which is physiological signals of heart function. So it's interesting that there is a model at Columbia that is being trialed right now that suggests, which is a ResNet-based model, that says that you can detect structural heart disease, structural issues with the heart, from ECG signals. So the cardiologist collaborator we work with had a question of whether adding X-rays collectively to ECGs already can improve SSG detection. Why is this question important? Because then we can actually say every time a patient gets an ECG, which is very common every time they have a cardiac complaint, you can also take an X-ray and predict whether or not this person will go on to get a diagnosis of SSD. But if you're going to change the policy of collecting X-rays, then we better have a very strong justification that it actually helps. But what is happening is X-rays are collected for a very specific reason right now in any given healthcare institution, has nothing to do with structural heart disease. And so what we are seeing is data from a particular distribution, but once we deploy the model, if we assume that X-rays are actually informative, the induced distribution is going to look slightly different. This is essentially down to the fact that the missingness mechanism will change going from the train to test. And so if we don't adjust for that, we are going to come up with biased estimates of informativeness. And so that's what we are trying to do. If we really are interested not in the question of just predictive utility of adding a modality, but what is the inherent information in X-rays about structural heart disease, then we would want to look beyond just performance and something like an information theoretic notion of performance. So we started with a decomposition that was proposed a while ago that decomposes mutual information between, say, two modalities, X1 and X2, and the label such as structural heart disease Y, into unique information in each modality, shared information that is common to both modalities, and complementary information, which is you will only get that information when the two modalities are available to you together. And I'm not going to get into how you would even go about doing this in high-dimensional data. You can look at the paper, but the idea is that you have to account for the mismatch in the distributions, and the implications are actually quite significant in that even for a very simple case of AND gates and OR gates, you can see that you can get biased estimates of information decomposition if your data consists of missingness. And if you account for it, you can actually get slightly better performance. And with that adjustment, we can actually claim multiple things in this particular clinical problem, which is that first, X-rays are absolutely not informative on top of ECGs for structural heart disease. And that essentially means that we should not collect X-rays in order to do structural heart disease detection, particularly using deep learning. And second, if we wanted to choose one modality between ECGs and X-rays, we better use ECGs because the unique information within ECGs is much higher as far as structural heart disease is concerned. So what this means is, even without modeling the temporality, if you don't account for the potential missingness mechanisms or the challenges that exist within the training data right now, we are likely to miscalibrate the value of any particular data source. So ideally, it would be nice to not have to think about every possible scenario of distribution shifts and try to overcome it. So we've been looking at how can we have models that can characterize their own uncertainty and then act on that uncertainty. And so under severe distribution shifts, when things like probabilistic adjustments like IPW are not going to work, the only choice is to inform data collection. And so we've been looking at how do we, whether existing notions of quantifying uncertainty with deep learning models, we have to stick to deep learning because we are modeling high dimensional multimodal data, can reasonably quantify uncertainty. And using that, we are looking at bandit and planning frameworks in order to inform better data collection that actually can help reduce its own uncertainty. So the model needs to act on its own reasoning of what is the next best data sample for which you may want to collect an expensive label for, like tell the patient to go get an ultrasound for, so that we can understand how the model might generalize to a population that is very different from the training population. And I'm not going to go into the details of this because we are close to time. But in general, all I'm going to say is that we have to start thinking about how to integrate these kinds of frameworks into models that we use as backbone, such as foundation models or these massive autoregressive models. And so if we try to do that, then we can see that even a little bit of planning, which we propose using our end-to-end autodifferentiable framework that looks at Bayesian neural networks as a way to quantify uncertainty and then plan around that, does reasonably well compared to state of the art. And we are looking at the utility of this proof of concept in some healthcare tasks that we are working on. With that, I'm going to stop here and just emphasize that we are at a stage where the impact of AI and ML in health is not as much as we would like, despite all the work that's happening in the past decade or more. But that essentially requires some engineering effort in terms of understanding where these systems are breaking down and then overcoming those challenges. And typically, I like to think about these in terms of distribution shifts, which is a good abstraction for us to start to address these engineering challenges. The most important thing is the lack of benchmarks. And benchmarks have been very important to characterize empirical progress in machine learning, but good benchmarks are still hard in AI and health literature. As you saw, the foundation model paradigm looks promising somewhat, but is fragile, finicky, and not necessarily in a place where we can just say, let's deploy these models. And finally, a good example of what might make its way to practice is methods that actually integrate with these kinds of probabilistic or foundation models that people are already enthusiastic about using and are using for things like diagnostic reasoning. And with that, I'm going to stop and happy to take questions.